we'll go. Okay, well, as I said, good afternoon, everyone, and welcome to Paediatric Teaching. I wanted to talk today about jaundice and liver disease in children. I particularly wanted to focus on liver disease, more that than on neonatal jaundice, and I'll explain why. Neonatal jaundice is a somewhat separate topic, but we'll cover that to start with, and then we'll talk more about liver disease, the different types of liver disease and how it's managed. So I'll speak a little bit about neonatal jaundice. About when you're thinking about neonatal jaundice, you need to think about physiological states and pathological states. Most of it's physiological, but some of it's pathological, and making that distinction is important. So I'll say a little bit about treatment, which is mostly, again, about the reduction in jaundice in physiological states rather than the treatment of liver pathology. And then I want to talk more about liver dysfunction and liver failure in older children outside the neonatal period. And so I want to talk a bit about the liver anatomy and physiology. I mean, again, we talk a lot about respiratory anatomy and physiology, or cardiac anatomy and physiology, but just going over again the anatomy and physiology of the liver can help us understand what different types of pathologies there are, what investigations might be useful, and what treatments might be useful. So from that, we'll talk a bit about tests of liver function, because it's important that we know what the different tests tell us and how they indicate what type of liver disease a child might have. We'll talk a bit about clinical signs of liver disease, and then I'll talk a bit about the different types of liver disease that occur in children commonly, and how we can manage liver disease and liver failure. So that's what we'll talk about today, if we can get through it. So, as I said, neonatal jaundice is a bit of a separate topic to liver disease, because most of neonatal jaundice is physiological, but it's important to sort of be able to make that distinction, and usually the distinction is made because of the clinical features. That is, the jaundice is not too early, not too high, not too long. So what that means, not too early, not before the first day of life. Any jaundice in the first 24 hours of life is pathological by definition. And it's not too high, because if the level of jaundice, the level of bilirubin gets too high, then it ceases to be likely to be physiological, and it may be due to some other cause, such as blood group incompatibility, for example. And then it's not been 2 weeks, because most physiological jaundice will resolve within 2 weeks. So physiological jaundice is different to breast milk jaundice, and we see a lot of benign jaundice in neonates, either because of physiological jaundice or breast milk jaundice. Both of those types of jaundice are benign. They don't indicate liver disease. They just indicate natural processes that are occurring in newborn babies. The reason for physiological jaundice is the breakdown of hemoglobin F. So if you remember, when babies are born, they have a relatively high amount of fetal hemoglobin compared with their adult hemoglobin A and A2. But hemoglobin F breaks down quite early in the first few days, and that's why babies get jaundice beyond day 1. Again, not too high, and it's always resolved by 2 weeks. Breast milk jaundice is, again, it's not physiological, but it's not pathological either. It's quite a benign form of jaundice. It occurs in about 40% of all babies that are breastfed, and it presents in the first 2 to 3 weeks, and that can go a bit longer. It can persist beyond 12 weeks. It doesn't mean it's liver disease. It's really a diagnosis of exclusion. Those babies are well, they're thriving, they're gaining weight, and when we look at their stools are dark. They're not pale stools. If you had a baby that was jaundice beyond 2 to 3 weeks of age and up to 6 or 8 or 12 weeks of age, we wonder about whether they had biliary atresia. And the distinction you can make is that they have bile pigment in the stool. It's not what we call acolic or pale stools. They have bile pigment in the stool. That makes it much more likely they've got breast milk jaundice. The reasons for breast milk jaundice have been investigated in various studies, and it's thought to be due to the fact that breast milk increases the enterohepatic circulation of bilirubin. Bilirubin is made in the liver from the breakdown products of heme. It's excreted in the bile, and then most of it's excreted in the stool. But when the baby's being breastfed, then they just absorb a bit more back into their bloodstream. So instead of excreting most of it, they absorb some, and we get an increase in what's called the enterohepatic circulation of bilirubin. So it's enterohepatic circulation of lots of different things, including medications. Some drugs go through this enterohepatic circulation from the gut back into the liver and down into the gut again. And that just increases the blood level of bilirubin and sometimes other drugs. So there's also another theory that says that breast milk has an enzyme that deconjugates intestinal bilirubin that makes it less soluble and therefore less likely to be passed in the stool and to be reabsorbed. So there's a couple of reasons why breast milk might cause jaundice, but it doesn't cause liver disease. And the important thing to do is recognise that these are well babies, they're thriving, they've got dark stools, not pale stools, and you don't need to do any other treatment. Don't withdraw their breastfeeding, just keep breastfeeding, it'll go away. It can sometimes make them sleepy, and so some breastfed babies, because they're well fed and also because they're jaundiced, become sleepy, and it's a benign problem, but it's very, very rare that the bilirubin goes to a level that will cause any problems. Usually, some sunlight is good, or sometimes phototherapy is needed. I usually measure the bilirubin levels weekly just to make sure that it's stable in a safe range, and then it's coming down. I mentioned before how bilirubin. I mentioned before about the sort of physiology of bilirubin, but you probably know bilirubin comes from the breakdown of red blood cells. Now, red blood cells have a half-life of 120 days, so they're always being broken down, and they're broken down in the spleen just over time. The red cells that are aging, they start getting broken down, and bilirubin is produced. Now, it's first produced as unconjugated bilirubin or direct bilirubin. It then gets combined with albumin, and it's still unconjugated, and it then circulates in the bloodstream. In the liver, in the hepatocytes, there's an enzyme called iodine glucuronidase which makes bilirubin come back and makes glucuronic acid, and that is a conjugated form which is more soluble and can be excreted in the bile and also excreted in the kidney. So then from the gastrointestinal tract, after that bilirubin is excreted in the bile into the gastrointestinal tract, and it's broken down by gut bacteria to urobilinogen. So I will have gut bacteria, one function of which is to break down conjugated bilirubin, and most of that is excreted in the feces, and about 2% is absorbed and excreted in the urine, and then normally about 80% gets redirected back from the gastrointestinal tract back to the enterohepatic circulation through the portal system into the liver and goes through the process again. So that's the circulation of bilirubin, and it explains why there's some conjugated and some unconjugated bilirubin sometimes present. There are ways in which you can classify newborn jaundice, and again, I said that most neonatal jaundice is physiological. That is, it's not too early, it's not too high, and it's not too prolonged. But sometimes you see jaundice that is what we call pathological, and it may occur too early, which is in most cases is due to hemolysis, not just the normal breakdown of hemoglobin F, but usually ABO incompatibility or some other form of hemolysis, sometimes G6PD deficiency, but typically ABO incompatibility if it's occurring early. Sometimes it can be too high, and that's again hemolysis due to ABO incompatibility or infection, such as a bacterial septicemia, or sometimes congenital malaria can cause it. Other congenital viral infections, intrauterine viral infections like syphilis or other intrauterine viral infections, the torches, so-called torches infections. And then sometimes jaundice is too prolonged. And certainly breast milk jaundice is prolonged. It often goes beyond 2 or 3 weeks, even, as I said, up to 12 weeks. But there are some other diseases, some other pathological causes, like hypothyroidism, that produces typically conjugated hyperbilirubinemia for a longer period of time, or malaria, congenital malaria or acquired malaria in the newborn period. Some other forms of hemolysis, such as G6PD deficiency, particularly, and then some other congenital hepatic enzyme abnormalities like Crigler-Najjar syndrome, which impairs liver conjugation and excretion of bile, or Jaundice syndrome, which is a bit similar. Then that's when a baby has high levels of unconjugated bilirubin. That is, it's not yet been conjugated by the liver with glucuronic acid. But when we've got high levels of conjugated bilirubin, that is direct bilirubin or bilirubin, or high levels of both conjugated and unconjugated bilirubin, the most important thing to do is think about biliary obstruction, like biliary atresia is probably one of the most common causes of cholestatic liver disease in newborn babies and very young infants. There's some other causes too, which can usually cause a mixture of conjugated and unconjugated hyperbilirubinemia, like bacterial infection or malaria, or viral hepatitis or galactosemia, or the torches infections, they can cause it as well. So one ways of classifying neonatal jaundice as being physiological or pathological, as being benign or something more serious, being cholestatic or not cholestatic. So that's ways of classifying that. There's good guidelines on when to give phototherapy in newborn babies, and they roughly are in any newborn baby where jaundice occurs on day 1. That therefore is pathological. So you should start the baby on phototherapy and investigate the cause. In preterm babies with jaundice, you should put them on phototherapy if they're less than 35 weeks, because they're much more prone to sinus toxicity with bilirubin. If the palms and the soles, palms of the hands and the soles of the feet are jaundiced at any age, be it even at a few days of age when many babies are jaundiced, if their palms of the hands and the soles of the feet are jaundiced, then you know that their bilirubin is quite high. So even if you can't measure bilirubin levels, look at the distribution of jaundice and how extensive it is across the baby's skin. If the palms and the soles are jaundiced, then the babies are probably quite deeply jaundiced. I usually do phototherapy if the baby's got a big cephalon hematoma or significant bruising from a traumatic birth. If they're jaundiced on day 1 or 2, certainly give them phototherapy, because you can imagine that as that blood is in the cephalhematoma is broken down, then their bilirubin level is going to rise further. So as a preventative measure for the bilirubin rising further, then it's worth giving phototherapy. And if the jaundice is due to hemolysis, then they should be under phototherapy. So there are clinical indications independent in a way of the level of bilirubin, because in many cases it's not possible to measure bilirubin or get the results back quickly. So if I see a baby with any of these clinical features, then it makes sense to measure the bilirubin and then put them under phototherapy until you've got the level back. The nanograms to help you decide when babies need phototherapy, and as I said, you should combine such nanograms with the clinical assessment of jaundice. And there was pretty good evidence that if a baby is jaundice, as I said, on the palms of the hands and the soles of the feet, then they have a level of bilirubin that's so high they need to be under phototherapy. If there's no jaundice below the nipple line, usually the level of bilirubin is below 205. Then if the jaundice is only involving the face or the conjunctiva, but not below the nipple line, they can be confident that the bilirubin will be relatively low. They will be less than 200. But sometimes the jaundice can be below the nipple line. It doesn't mean it's over 205. So it's always useful if you can measure the bilirubin level. As I said, good nanograms to indicate when a baby should receive phototherapy based on their age in hours or days, and the bilirubin level, and whether they're preterm or term babies. So you need to take those three things into account. I'll send this around with the slides, and you can have a look at it. But as I said, it's a function of the age of the baby, the bilirubin level, and whether they're preterm or term babies, and also whether they've got any other comorbidities or any other reason why they might have they might have an ongoing elevated bilirubin, such as hemolysis or a large kephalhematoma. The hospital care for children, there's just on the use of phototherapy and exchange transfusion, independent of those clinical features I talked about, are the levels of bilirubin that for which you should give phototherapy, whether a baby is a healthy preterm baby, a healthy term baby within 35 weeks, or a preterm baby. The same for exchange transfusion. When should you, when phototherapy be insufficient, then you should add an exchange transfusion to try to remove the levels of bilirubin. Well, there's a nomogram for this too. When should a baby where phototherapy is insufficient has too high a bilirubin level, and you should give it an exchange transfusion. I won't talk about an exchange transfusion today because they're rarely given, but it's useful to know the clinical reasons why you would give phototherapy, and also the levels of bilirubin that you should give phototherapy, and to know that they're dependent on the age of the child, the gestation of the child, and the level of the bilirubin. Now, I want to now talk more about liver disease. And to understand liver disease, it's very useful to understand something about the functional anatomy of the liver. Now, as I said, we often talk about the respiratory physiology or cardiovascular physiology, but most of us have forgotten about our liver physiology and liver anatomy, I think. And so I just want to try to explain it in a fairly simple way that just describes the different components of the liver and what they do, and why certain tests tell us different things about different parts of the liver. So let's talk about the anatomy first. When you look at the liver parenchyma, this is the background is a microscope slide of a normal liver. If you look at the normal liver parenchyma, it's packed with hepatocytes. Now, hepatocytes are just liver cells, but they have a number of different functions, lots of different functions that are very important. A lot of them relate to glucose and protein, so liver cells, there are so many different things, but try to think about it in terms of what they do for glucose what they do for different proteins, and the production of bile. So we'll talk a bit more about the functions of hepatocytes, but hepatocytes are involved in the taking up of glucose and storing it as glycogen, in the breakdown of glycogen to produce glucose in times of starvation or fasting, in the production of non-glucose for provision of energy, in the breakdown of glucose in metabolism to produce energy, the synthesis of lots of different proteins, albumin and clotting factors, and the production of bile. There's other functions of the liver which I'll talk about, but just know what the hepatocytes do. This is important. It might seem esoteric, but it has when you're thinking about a child who's got liver disease, you need to think about all of those things, and I'll explain why. The liver is also made up, apart from our hepatocytes, the liver is made up of what's called stellate cells, which just provide the functional architecture of the liver. So they're just fibrous tissue that the hepatocytes sort of sit in, and they don't do so much, the stellate cells. They can become more scarred and more fibrotic depending on if there's more inflammation, and that can lead to liver cirrhosis, for example. I won't talk too much about that, but hepatocytes, stellate cells, which are just the fibrous architecture of the liver, Kupffer cells are very important. They're macrophages that are the immune cells of the liver, and it's exposed to toxins all the time from the food we eat, from the medications we take, from the other environmental toxins we might ingest or might get into our bloodstream. The liver deals with all that. Bacteria that translocate across the bowel into the porous system, the liver deals with those things all the time, and it deals with them through the macrophage-like immune cells called Kupffer cells, which are in the liver. So know about those things. The liver has very important immune function within the body. Apart from the liver parenchyma, there's the bile ducts and the bile canaliculi. So the bile ducts are just the bile ducts. Bile is produced by the hepatocytes, and then it passes down the bile ducts and the bile canaliculi, which are just like what they say is lakes of bile within the liver that then pass into the bile ducts and then into the common bile duct and excreted into the gastrointestinal tract. Then there's the blood flow, the blood vessels that flow to the liver and from the liver. And it's important to know the blood flow anatomy of the liver. That is that most of the blood that's going to the liver comes from the portal vein. And that brings things from the gastrointestinal tract. So it will bring intestinal nutrients. It also brings intestinal nutrients like proteins and fats. But it also brings other things like bacteria, for example, that come from the bowel, and so that bacteria doesn't get into our bloodstream and cause infections within our body, we have the liver, and the liver will filter out those things and will filter out many medications, and so some of that is absorbed from the gastrointestinal tract. So 70% of the blood flow to the liver comes from the portal vein, and 30% comes from the hepatic artery, which of course comes off the aorta. So therefore that's an oxygen-rich environment. It carries oxygen from the left ventricle to the aorta to the hepatic artery to the liver. So that supplies oxygen to the liver. Whereas the portal vein is low on oxygen, of course. The portal vein has a low amount of oxygen, but it has all the nutrients that the liver needs in terms of glucose and proteins and fats, etc. And then the blood that's coming from the liver, the blood flow that goes from the liver is a hepatic vein that flows to the inferior vena cava, usually to the IVC. So just know your blood flow anatomy to the liver from the liver. This is important because it's again it tells us something about liver disease, and also about the normal metabolism of nutrients that are ingested, and how one of the functions of the liver being the detoxification of different substances that we might ingest. But the liver, as I said, has many functions, and you can break them down into a number of different important areas. Protein synthesis is very important. So if the liver becomes dysfunctional, then the proteins in the body aren't produced, especially the clotting factors and especially albumin. And albumin has a half-life of about 3 weeks. So usually if the liver fails, the albumin level drops slowly. But clotting factors have very short half-life. And if the liver fails, then you get coagulopathy and abnormalities of these clotting factors very quickly. And that's why you can get bleeding as a function of liver failure or liver dysfunction. So protein synthesis is a very important function of the liver. And the liver produces, as I said, and excretes bile. That's a very important function of the breakdown products of heme within the red blood cells. It also has an important function of detoxification of toxins and metabolism of drugs. There's this enzyme system called the cytochrome P450 enzyme system. It processes nutrients that come from the portal vein. So the storage of glucose is glycogen, the mobilization of glucose, the breakdown of glycogen to mobilize glucose in times of fasting. The storage of fats within the liver, if there's excessive amount of fats ingested. It also has an immune function, as I said, through the Kupffer cells, much of which is linked to this detoxification of the blood. And the liver also has a function of the regulation of growth and endocrine functions. It's an endocrine organ, the liver, and it produces things like insulin-like growth factors, which are important for growth in childhood, and angiotensinogen, which I have mentioned before, which converts angiotensin to angiotensin 2 and leads to it's part of the cardiovascular system that maintains blood flow, maintains blood pressure, and regulates fluid management within the kidneys. So if a child has chronic liver disease, then they have growth failure, and it's partly nutritional, but also partly because they don't have the endocrine function that the liver normally has. So I wanted to try to combine what we've talked about the liver structure and the liver functions, and talk about the different tests that we do tell us different things about the liver. And so I'm going to talk directly about laboratory markers of hepatocyte dysfunction, about biliary dysfunction, about liver synthetic dysfunction, which is most about hepatocyte dysfunction, but not an extreme severity. If you've got just mild liver inflammation, then you get some tests that are abnormal. But if you've got extreme liver dysfunction, that is, instead of being just inflamed, the liver cells stop working, the hepatocytes stop working, then some other tests can tell us a lot about that. The markers of impaired hepatic detoxification and tests of the structure of the liver. So these are many of those tests you'll be familiar with and will do regularly, but you might not fully understand just what they mean or what they tell us about the liver. But the first one is the common, what we call LFTs, or liver function tests. And actually they're markers not so much of liver function, but just something going wrong with the liver. Any form of inflammation or drug toxicity to the liver, they show the transaminases rising. And so the ALT is more liver specific. The AST can come from skeletal muscle or cardiac muscle or the breakdown of red cells. So we're looking for liver dysfunction and trying to separate it from other forms of where there's abnormal liver function tests, then look more closely at the ALT. The ALT will be elevated if you've got inflammation because of hepatitis, or if you've got any form of hepatocyte damage, trauma, drugs, infection, immunological injury, ischemia, if you like. The child's had a hypoxic injury, that they're likely to have a high ALT, abnormal liver function. They may also have a high damage AT and other things, but particularly the ALT will be elevated. Now, in extreme forms of liver disease, not only is there some degree of damage or inflammation that might just recover, if there's extreme necrosis of the liver or fibrosis like sclerotic liver, that's extensive. I mean, sometimes the transaminases are not elevated; they're actually not elevated. It's because there's not enough liver cells to produce ALT. But usually, in that circumstance, you can get a clue showing the fact that there's really some liver disease by other things, which I'll mention shortly. So, just to know that most of the things we measure, those LFTs, what they tell us. They don't tell us exactly what's wrong with the liver. They just tell us there's some inflammation or immunological injury or trauma or ischemia or drug or toxin effect on the liver. That's something like that. Some of the LFTs are a bit more specific for different. The ALT tells us something about hepatocytes. But if you want to look at whether or not there's a problem with the biliary function of the liver, you look for the alkaline phosphatase and look for the gamma GT, the gamma transferase. The alkaline phosphatase, if you've got obstruction of bile ducts or some sort of damage to the bile ducts, then the alkaline phosphatase may be elevated. It's not a very specific enzyme, though, ALT, alkaline phosphatase, because if you've got injury to the kidneys or the intestine or even a breakdown of bone, then the alkaline phosphatase will be elevated. So it's not, ALT is not specific for the liver, but it tells us that when it is related to the liver, it tells us something about bile duct flow, usually. It's a bit more specific and sensitive just for biliary disease. So usually that elevates quite early if you've got drug-induced biliary disease or any other form of biliary obstruction. And so it can be elevated sometimes when you've got kidney or intestine, kidney or pancreas or intestinal disease, but it's a bit more specific for the liver than alkaline phosphatase. And then you've got the level of bilirubin. So the things that tell you that there's biliary destruction, biliary dysfunction rather than hepatocyte dysfunction is that the ALT, the gamma GT, and the bilirubin level will be usually quite high. Whereas if there's just inflammation of the hepatocytes, then it's the ALT particularly that will be elevated. Now, we're thinking about how someone has this child's liver disease, and it's really important to look at the markers of the hepatic synthetic function. So not just whether there's inflammation of the liver, but are our liver cells working or not? And if they're not working, then you get, as I said, a very high, you lose your clotting factors quite quickly within a couple of days, and the INR, or the prothrombin time, will be very elevated. But that's the most sensitive marker of liver failure is a high prothrombin level. So look at the coagulation, and if the prothrombin level is high, but the ALT is not so high, then think that it might be related to liver failure. Usually the INR might be 1.5 or 1.5, but sometimes even when there's been liver failure for a day or two, like severe liver failure, then the INR will rise to 2 or 3 or 4. I had a child this week who had an INR of 10 with severe liver failure. So it's important to be able to measure the INR. As I said, the albumin, if you see a child that's got an albumin level that's very low, liver disease, then it may be that the liver disease has been going for some time, because usually it takes some time for the albumin level to fall. But it might also be that there's something else going on. And if you've got liver disease related to severe sepsis, then sometimes that albumin level just drops because albumin leaks out into the tissues with sepsis. And also the albumin is like a negative acute phase reactant. That is, when you've got a fever or systemic inflammation, sometimes the albumin level will just drop, just like some other things like the C-reactive protein or the procalcitonin or the ferritin. They are elevated. With some acute phase reactants, they become negative and they drop. So albumin drops when you've got sepsis. I'm just going through those things because you measure those things all the time, and it's just useful to know, I think, what they mean. There are some markers of impaired detoxification, and again, as the liver disease gets worse, you will see these features, because the liver is not only not producing the proteins that it needs to do, but it's also not handling the toxins that it usually does, the toxins of the products that it usually does. Now, ammonia is an important one. Ammonia is like a breakdown product of protein. So we're eating protein, and protein has to be broken down, and that produces ammonia. We have mechanisms by which we can deal with ammonia, but in liver failure, where the hepatocytes stop metabolizing ammonia, then it will become very elevated. And when the liver, when the ammonia level is very elevated, that's what the cause of hepatic encephalopathy is, because of a very elevated blood ammonia level. And so ammonia is a very sensitive marker and liver failing. And if you've got a high iron dysfunction, it's useful if you can to measure the ammonia level, because we can know about the severity of the hepatic encephalopathy. Usually, lactate will be elevated as well in severe liver disease. So if you see a high lactate or lactic acidosis with a high ammonia and a very low blood glucose, that's another marker that's very important, is to monitor the blood glucose, because the liver manages our glucose metabolism within the body. And if your liver is failing, then you'll often be hypoglycemia. So the combination of a high ammonia level, of high lactate, and low glucose, persistently low blood glucose, suggests liver failure. So in the last part of the talk, I wanted to talk about different types of liver disease in children. So we talked about the anatomy and the physiology, the functions of the liver, the tests that tell us something about the liver. But I just want to try to cover some of the liver diseases that occur in children. And you can think about them in various ways. But there's many different types of liver diseases, and there's many different manifestations. But certainly I can think about acute or chronic liver disease, liver disease that occurs in the young period and outside the young period, cholestatic liver disease, where we've got primarily conjugated hyperbilirubinemia, liver disease where we've got primarily liver hepatocyte inflammation or some hepatocyte damage. And then you need to think about, is it just liver disease? Has the child also got complications of liver disease? Like, do they have portal hypertension? Do they have what's called a hepatorenal syndrome, where they've gone into kidney dysfunction as well as having liver dysfunction? So it's when you see a child who's got liver disease, you need to think about all of those things. The clinical features of liver disease, I think, are well known to you, and obviously children become jaundice. You need to look for other things. Look in the urine to see if it's very dark, because they might have bilirubin in the urine. If their stools have pigment in it or not. If they have steatorrhea, that is pale stools, because they've got an absence of bile coming from the liver. If the child's got liver disease, especially if they've got conjugated hyperbilirubinemia, they'll often be very itchy And Paediatric, where it's extreme rich from conjugated bilirubin circulating in their blood, is very common. So those features are usually of children who've got chronic liver disease, who've got chronic polystatic liver disease. Then sometimes, obviously, I need to think about, has the child got hepatomegaly, and what type of hepatomegaly have they got? And the type of hepatomegaly they've got can give you a clue as to what the underlying liver disease is. These are all clinical features you can test at the bedside. So if the child's got hepatomegaly that's very tender, then they've probably got some form of inflammation of the liver, like hepatitis. If they've got a congested liver and they've got other signs of venous congestion, so distended veins, or they've got a pulsatile liver, then they're likely to have venous congestion from whatever cause. It might be constrictive pericarditis or something like that. That can cause hepatomegaly as well, but it looks different to hepatitis. Or they might have a liver that's irregular, or you might feel a mass like a hepatoma, or it might be hard, like if there's a liver tumour. And so, if a child's got hepatomegaly, don't just report, like if you're doing a short case or a long case or assessing a child, don't just report that they've got hepatomegaly, but describe what sort of hepatomegaly it is. Does it appear to be tender? Is it congested? Is it pulsatile? Is it firm or normally smooth or hard or irregular, or can you tell on this, etc.? So these things are really can help us at the bedside to try to understand the type of liver disease. Finally, do they have splenomegaly? Because remember I said that you need to think, well, do they just have liver disease, or could they have a complication of liver disease like portal hypertension, or could the presence of hepatomegaly, splenomegaly, could the presence of splenomegaly tell us something about the cause? So there are some causes of liver disease where we get splenomegaly just as part of the underlying disease, like hepatitis from say glandular fever, you often get splenomegaly, or hepatitis A, you often get splenomegaly. Obviously, with malaria, you can also get splenomegaly. So some forms of infectious hepatitis where you get splenomegaly as part of the disease, the infection, and there are some forms of chronic liver disease where they get splenomegaly because of underlying portal hypertension or as a secondary complication. Fourthly, what's the child having encephalopathy, or just sleepiness? What's the level of arousal like? And do they have things like a flap, a tremulousness or a flap related to alcoholic encephalopathy, which remember is related to high ammonia levels usually, and the ammonia is related to protein breakdown. And so if you've got liver dysfunction, you won't have protein metabolism, the number one driver ammonia, and you get encephalopathy. Some children with liver disease have skin changes. They certainly have itch, but they may also have plantar erythema or dilated abdominal veins. They might have fundamental features of chronic liver disease rather than acute form of liver failure. And signs of pulmonary uptake of portal hypertension, as I mentioned, being splenomegaly primarily, but also dilated abdominal veins. And because low is a organ that regulates endocrine function, then a child with chronic liver disease will have growth failure. So we can make a distinction between acute and chronic liver disease based on those clinical features, and we can make a distinction between polystatic liver disease and hepatitic liver disease based on these features as just clinical signs at the bedside. So I think those things are very important. Because if you see a child with liver disease, it's the only way to arrive at a diagnosis is to think: is it acute? Is it chronic? Is it polystatic? Is it hepatitic? That's a good start in terms of understanding the child's liver disease. I wanted to just touch on the venous drainage of the gastrointestinal tract and the drainage and the liver venous system. I did mention this before, that 70% of the blood that goes to the liver comes from the portal venous system, and 30% comes from the hepatic artery, and the hepatic vein drains the blood away from the liver to the inferior vena cava. And what that does is explain why when you've got liver disease, you can get hypertension. And it's good to understand this, I think, conceptually, to understand why portal hypertension occurs in liver disease. And it occurs because of not only the venous system is like all venous systems, but also the portal venous system has a very low resistance system and very low pressure. The pressure in the portal vein is usually very low. But if you've got inflammation of the liver, or if you've got sclerosis of the liver, fibrosis of the liver, anything that increases the resistance of the inflow in the portal vein, and that will increase the pressure in the blood in the portal vein, so portal hypertension. And the body's response to that is to produce collaterals that can reduce the flow. Collaterals are new veins that occur, that grow, new veins that grow around the existing veins. So try to maintain the blood flow from the gastrointestinal tract to the liver without undue pressure. And those veins that occur in all different parts of the gastrointestinal tract, like from the esophagus to the stomach to the small intestine and right down to the colorectal area, they can cause varices. So varices are like varicosities or dilatations of veins, existing veins, or collateral flow veins that open up. They're usually closed vessels that open up and they become dilated and varicose. They dilate and varicose. And because they're abnormal blood vessels under high pressure, then they can bleed. And that's why you get esophageal varices or gastric varices, and or sometimes you get colorectal varices, hemorrhoids, because of high pressure within the portal venous system. Sometimes also you get other veins opening up that drain from, say, the spleen. If the splenic veins are under high pressure, draining from the spleen to the kidneys, so you get splenic varices as well. So I just think it's useful to understand that, to understand why you might get from liver disease, you can get portal hypertension. There's some other good reasons for portal hypertension too. Obviously, if you get any other blockage of the portal vein, the same process will happen because of the build-up of pressure within the portal venous system, leading to varicose veins within the gastrointestinal tract. That can occur if you've got portal vein thrombosis or obstruction, and even if you've got the hepatic vein, that drains the blood from the liver to the inferior vena cava. If you've got a hepatic venous obstruction, a condition called Budd-Chiari syndrome, then the liver will be very congested, and portal hypertension too. So I mentioned before malnutrition as being an important cause of neonatal jaundice, and just to cover this again, it causes jaundice usually about 2 to 3 weeks of age. Sometimes the babies are jaundice in the first week of life, but typically they become clinically evident jaundice in about 2 weeks of age. They have pale stools and no results. So they have 8 pale stools and usually quite dark urine. And mostly they are, when it's elevated, is conjugated. Most of it is, at least. In the first few weeks, it's often about 20% conjugated, and then it rises progressively over the first month when most of it's conjugated. And because it's a viral duct problem, they have a high alkaline phosphatase and a high GT, but liver transaminases, ALC, will not be very high. And they often have vitamin K deficient voting, like a high time. And it's not because their cells aren't making vitamin K, it's because the the fat-soluble vitamins are not being absorbed. So the fat-soluble vitamins will only be absorbed if you've got bile flowing through bile ducts into the small intestine to break down the fats and to absorb the vitamins. And so in ADK, which are fat-soluble vitamins, if you've got no bile salts flowing into the gastrointestinal tract, then you're vitamin K deficient. It's not because the cells are failing, it's just because there's not enough bile in the GI tract. So body weight transfer is relatively common, and it occurs in females more often than males. This was a young baby who was at 6 weeks of age, must do conjugated hyperparathyroidism, and deep jaundice. And this ultrasound, which shows what you can see in an ultrasound of a baby who's got big atresia, extra bile ducts, like the bile ducts outside are just not formed. There's no common bile duct. Usually the bile data is very small as well. And within the liver, there's sort of what they call pools of bile. Bile's been made, but it can't be excluded because there's no, the bile ducts are atretic, or they're not patent. There's an operation that's done. I won't go into the surgical approach to this much, but there's an operation that's done for babies who have atresia. Because their bile ducts, the common bile duct is not working, the operation is to attach, instead of the bile duct flowing into the small intestine, then the small intestine is anastomosed directly into the gut surface of the liver. So as the bile drains through the liver, it anastomoses directly with the small intestine. It's called a if you would have thought about this. Again, it doesn't matter too much to understand this, except that that's the treatment for those who have atresia, but it's usually a temporary treatment because most babies who've got atresia, this procedure called a Kasai procedure, the Kasai ends up failing because they end up with chronic sort of ascending cholangitis. That is because you've got the bacteria in the gastrointestinal tract, they can throw up into the liver and you get what's called ascending cholangitis. So the Kasai procedure is necessary for babies with atresia, but if you've looked after some of these children who've had Kasais, then usually they go into liver failure at usually about 2 years of age. I just want to cover lastly the causes of acute severe liver disease. So not chronic liver disease, not cholestatic liver disease, but acute severe liver disease. And from what I've said, there's lots of different causes of liver disease, from viral hepatitis to drug toxicity or septicemia, even enterococcal bacteria in the from streptococcus pneumonia often causes acute liver inflammation. The children have signs of pneumonia, but they're often quite jaundice. Malaria, of course, too, and some forms of liver abscesses. So when we're thinking about a child who's got acute, not chronic, but acute liver disease, they come in having that they become acutely jaundiced, then you need to think about all of these things. Could it be viral hepatitis, or drug toxicity, or septicemia, or pneumonia, or abscess? This was a small baby. This was a small baby and E. coli septicemia and liver failure related to that. So jaundice and acute liver failure can occur from many different diseases. I'll just briefly talk about a few of them. Hepatitis A is the most common, and it's often a relatively benign infection. Almost all of us have had hepatitis A at some stage. It's waterborne and foodborne, and it's febrile spread. It's an enterovirus. And most of us have been exposed to hepatitis A by the time we're 10 years of age. But if you measure hepatitis A antibodies, most of us have got hepatitis A antibodies. But for most of us, we don't have any symptoms. We might have some diarrhea for a while, but we don't get liver dysfunction or acute hepatitis. But if you are going to get it, then the incubation period is relatively long, 2 to 6 weeks if not exposed to hepatitis A. And if you get symptomatic, like many people don't, but if you do, then you generally get vomiting, fever, jaundice, and other right upper quadrant pain. It's very rare with hepatitis A, even if it does occur, to cause permanent hepatic failure. Most children just get jaundiced, they have right upper quadrant pain, they're vomiting, some diarrhea, and they slowly get better over about a month. And from hepatitis A. In children who've got this syndrome of acute hepatitis A, it's very important to look also for G6PD because those children are at risk of getting hepatitis A, and they may have both hemolysis and hepatitis. So sometimes they're very high. It's not just due to hepatitis A, but it can be due to G6PD and hepatitis A at the same time. And the clue is that the children who've got G6PD have a very high reticulocyte count. So even if you can't measure G6PD enzyme levels, you can look at the blood film and see if they've got a high retic count, which again is indicating that they've got production of new red cells. Hepatitis A, the most important, the most common cause of acute liver disease, but really causes acute permanent hepatic failure. The things that I mentioned earlier on, that it causes a high transaminase and a high bilirubin, but not so much neuropathy or low or those things. Usually it just goes away by itself. You don't need any particular treatment. I think the second most important cause of liver dysfunction or liver acute failure are drugs. And there are many drugs that we use that can cause the liver to malfunction, and particularly common drugs that we use for TB and some antibiotics. So as more and more people access paracetamol at pharmacies and over the counter or anyway, the dysfunction related to paracetamol. They're not normal doses. If you take a normal dose of paracetamol, you won't get liver failure. But then in overdose, you'll see liver failure. It usually occurs 2 to 4 days after taking an excessive dose of paracetamol. Whereas INH and triazonamide and rifampicin cause they can cause liver dysfunction, not from too high doses, but just the effect it has on the liver in a small proportion of children, usually less than 5% of all children who have those drugs, INH and pyrazonamide and rifampicin, will get liver dysfunction. And mostly it goes away when you stop the fertility drug that's causing the liver dysfunction. There are some antibiotics that cause liver disease, and you can particularly tell it's antibiotic-related drugs because they often have systemic symptoms too. They often have arthralgia or a rash, a rash, and sometimes they have eosinophilia in their blood. So look in their full blood count to eosinophilia. And in some children who are on antiepileptic medications can get liver disease as well, particularly if they're on sodium valproate. About 5 to 10% of children who have epilepsy on sodium valproate will get some liver dysfunction, and it goes away when you stop the drug, usually. Just to round out the causes of acute liver failure, so the most important ones are hepatitis A drugs, but also septicemia, like I showed you that with E. coli, septicemia, meningococcal pneumonia, and malaria. So you should always, any child who's got acute liver dysfunction, always treat them with antimalarials until you mark out the cause. And always treat them with antibiotics so that you have covered septicemia and meningococcal infection, etc. Another cause of liver disease, which is not as common, but you should think about is a liver abscess. Now, liver abscesses can be because of bacteria, but they can also be because of the liver. And it's important to be able to identify amoebic liver abscesses, and you can do this clinically, and you can do it by ultrasound. And the clinical features of amoebic liver abscess are that there is no painful hepatomegaly. And like I said, if you see hepatomegaly, that you need to think, is it just a bit tender because of hepatitis, or is there marked enlargement and local extreme tenderness? And liver abscess will be extremely tender. There will also almost always be a joint inclusion when you've got a liver abscess. So if you see a right-sided fusion with marked tender hepatomegaly, then think about the possibility of a child having a liver abscess. And it could be pyogenic, that was like bacteria. It could be a tuberculosis of the liver, or it could be a hepatoma, but it could be a liver abscess. So this was a child who had an immediate liver abscess, and you can see he's got, this is the ultrasound of the liver, and you can see he's got large abscesses running down the liver. But this is normal ultrasound, relatively normal liver, and here's an encapsulated large liver abscess. The treatment is drainage and anti-emetic therapy, metronidazole, tinidazole. That's much less common than the other causes like hepatitis or drug-induced or septicemia or pneumococcal pneumonia or malaria. But just think about it, I think. The treatment, this is my last slide, I'm really finished, but the treatment for jaundice and acute liver disease in liver children, I've just listed all the things you should consider in the treatment. If the child's got severe liver disease, then of course, until you make the diagnosis, then treat for malaria, give antibiotics that will cover the common causes of septicemia that would lead to liver disease. So I always give amoxicillin or ampicillin plus gentamicin plus metronidazole, because they'll cover pneumococcus, they'll cover E. coli, it'll cover anaerobes or maybe. You should have written some antibiotics because they can make the dysfunction. So always include triptioxane and toxicillin. Now, these are commonly given drugs, but if you've got liver dysfunction, then they can cause most cholestasis and liver dysfunction. So avoid those drugs in children who've got liver disease. I always give vitamin K, and if the iron is very high or they're bleeding during or fresh frozen plasma, fresh frozen plasma, think about their blood sugar, because if they've got progressive liver disease, their blood sugar level will be very low. If they can have some pantoprazole, which is reduces gastric acid production, or ranitidine, just to reduce gastric acid production, because these children are at high risk of stress ulceration of their bowel. Do an ultrasound to have a look at the architecture of the liver, see if there's any abscess or see if there's congestion of the liver, see if the bile ducts are there or blocked. You should get a proper ultrasound of the liver. Very important to consider drugs or toxins as a cause. Sometimes it's as simple as removing toxins or making sure that you've stopped all the potentially hepatotoxic drugs the child might be on. Now, if the child's getting worse and worse, then, and they seem to have features of liver failure, then there's a few other things you can do. If they're fully conscious with severe jaundice and you think they've got acute liver failure, then you can do the basic things, aerobic circulation, of course, plus reduce the risk of their encephalopathy by elevating the head of their gut, and sometimes giving cortisol if you think they've got hepatic encephalopathy. You can pay attention to their coagulation, their glucose, their kidney function, and their brain. So remember that the other systems, the other organs that are affected by acute liver failure. You can put children like this on a low protein intake, and you can try to decontaminate their gut. So to try to remove toxic proteins or proteins from the gut that would lead to high levels of anemia, and worsening hepatic encephalopathy. So there's a number of things you can do for children who've got some progressive worsening liver failure. They can support them for as long as it takes for the liver dysfunction to resolve. That's really what we're trying to do in children, in treating children who've got acute liver failure or acute liver diseases, to try to support all their organs until the liver failure has had time to resolve, and try to make the diagnosis of what sort of liver disease it is and treat it if it's possible to treat. So, okay, that's all I was going to say today, and I'm happy to answer any questions that you might have. But we talked a lot about different things in regard to liver disease, about jaundice, and about liver anatomy and physiology, liver function tests, and different sorts of liver disease and how to manage liver disease. I hope that's been useful to you today. I'm going to stop the recording now, and I'm happy to answer any questions you might have.